Medical Center, Tehran University of Medical Sciences. I'm very happy to be here today. And I think we can start, and if others are going to join, we will appreciate it. Okay, I think everything's okay. So today's class is about evaluation of the well child. Well, this is a very important part of our job as pediatricians and also general practitioners, because most of the children that are referred to pediatric offices and even to general practitioners are in fact not ill, but they need to be observed and they need to be searched for any possible problem. And there are things that we should have in mind about which I'm going to talk. Okay. So let's start the class. The content of today's session are evaluation, safety issues, development, and growth. First of all, we will talk a little bit about evaluation. Can anybody tell me what important factors we should pay attention to when we want to evaluate a child, each child that is referred to our office as general practitioners? Because today's class is about the general practitioners, not pediatricians, okay? What important factors you should pay attention to when a child comes to your office, a well child, and his or her parents are just asking you to do a checkup? You can turn on your microphone or you can write in the chat box. Parisa says growth milestones. Yes, that is a very important one. What other things? Well, I think we're having this class for only 2 now, but it's okay. I like private classes.
Hi.
Hi.
Hi. Thank you for your nice subject. If it's possible, I want to share in my idea in these sessions.
Great.
I think thank you. I think as a general practitioner or as a pediatrician, as a mother come to my office about his or her child, I will ask her about his or her weight, length, head circumference, about neurologic developments in terms of language and communications, and his or her appetites, and past medical histories and family histories about the siblings, and the important issue in the birth events or maybe admitted in hospitals. And that's for history.
Yeah, that is great. Thank you, dear Parisa. Yeah, that's true. That's totally true. And yeah, these are all the things that we're going to talk about today. Okay. So when a child comes to your office, as you have kindly mentioned, you should pay attention to the child as well as his or her parents. And you should check for anything in their history, in their physical examination, development, and growth that might be concerning, okay? So, of course, we should pay attention to parents' concerns. It means that when a child comes to your office, the most important thing is what she or he complains of and what their parents complain of, okay, or they're worried about. We should inquire about their illnesses since the last visit, and also you should check for physical examination, for growth, for development, and for the accuracy of nutrition, okay? You will provide some data, some information about safety issues, and you will do some screening tests if that is relative, if that is appropriate for the age of the patient. And about the immunization, you should give some consults and refer the patient if she is in the proper age for being immunized. So this is a comprehensive table. Excuse me. Comprehensive table talking about all the things that we should pay attention to in a child's supervision visit. Okay, first of all, you should focus on the child, then you should focus on the child's environment. When you focus on the child, you pay attention to the concerns of the child or the parent, you pay attention to the past problems and the follow-up of the past problems. Okay, you pay attention to the immunization and the screening tests. You will provide the routine cures. For example, you will give some suggestions about the eating, the sleeping, the elimination, and health habits. You should also check for the developmental progress. Maybe the patient has not met the milestones necessary for development. And you also pay attention to behavioral style and problems. When you focus on the child's environment, the first important thing is to pay attention to the family, then to the community, and then to the physical environment. You should provide a caregiving schedule for caregiver who lives at home, whether that is a parent or a grandfather or grandmother. And you should pay special attention to the parent-child and sibling-child interactions. Also, you should focus on family stresses, for example, the job of the parent, whether they have recently moved to another place, the finances, the illnesses of the family members, the deaths that have happened in the family, the marital status of the parents, and other interpersonal relationships. Also, family supports are very important because you can provide a special help for the child if you notify the correct family support. For example, you find a grandfather very supportive, okay? So if there's a major problem in the house, you can address this grandfather and you can rely on this grandfather and you can talk with him and you can provide support for the child. And about the community, well, caregivers outside of the family are also important too. For example, there might be a nanny or a teacher in the kindergarten. Peer interaction is very important, the school and work and the environment in those places. And also the recreational activities that the child is being involved in. Physical environment is also important because a very important issue in child's health is the safety issue, and I'll talk about it today. I'm not going to focus a lot on the newborn process because newborns are not usually referred to general practitioners, but sometimes when the mother leaves the hospital with her child, she will come back for a visit to the general practitioner, okay? Because especially in the cities, the cities of excuse me, I'm having a problem with my connection. Can you see my screen?
Yes.
Yes, okay. Yeah, especially in rural areas, the family tend to visit the general practitioner for a formal visit after the I am having a problem, but I think you do not have that problem. Okay. After their discharge, sorry. So you should know that from the days 3 to the 5th day of life of the newborn, it's important to do some metabolic screening. There are different theories, there are different suggestions about the metabolic screening in different countries, but the screening that is recommended generally is the screening of hypothyroidism, G6PD deficiency, that is favism, and phenylketonuria, and also hearing evaluation. This is very important, and it is usually done when the patient is still, when the child is still at the hospital. But if it's not done when they're at the hospital, it should be followed after discharge, okay? And you have time for doing it until the 1st month. It's very important to do this. So Another important screening is pulse oximetry. It should be done inside the hospital, but if not, you should do this in the follow-up, okay? And any saturation lower than 90% is very critical, is very important to be referred immediately. But another important factor is to find a difference of more than 3% between the two limbs, or between the right limb and the left limb, okay? And about hearing and vision, it's very important to pay attention to parents' concerns. For example, a parent might say that my 2-year-old seems not to be able to follow my voice, to look at me when I talk to him. So until 3 years old, it's very important to pay attention to what parents are concerned about vision. And until 4 years old, very important to screen for hearing problems, okay? And here I shared a picture of brainstem auditory evoked potentials. This is the test that we use for hearing screening. The patients will use headphones, and some sound will be played, and some transmitters will be placed on the forehead, so that the action potentials that are formed because of the triggering voices should be transferred to this platform, and then we can understand. It's a little difficult for me to understand, but the specialists know how to interpret this and to understand whether the patient has hearing difficulties. And also, this is the same case for vision screening. As you can see, the patient can see some stimulants, and then it will be interpreted via the transmitters here on the head. About anemia, it's important to know that all the patients should be screened, all the children should be screened at 12 months for anemia. But if the patient is preterm, it has a preterm birth, the screening should be done at birth and also at 4 months old. Okay, can you tell me why is it important to search for lead intoxication? We have certain screening strategies for lead intoxication. Can you tell me why is it important? You can both turn your microphones on or write in the chat room. Parisa raised hand. Yeah, you can talk, Parisa. I don't think you need to.
I think lead intoxication is not so common in our country nowadays, but it can be the root of anemia and some constitutional problems like stomachache or change in appetite or weight loss or don't gain weight for children. That is one of the most to complain of mothers that come to the general practitioner, general pediatrician, because of the don't weight gain, proper weight gain.
That is totally true. Thank you very much, dear Parisa. And Ranga has typed here, water chemical contamination, anemia. Yes, water chemical contamination can be a source of lead intoxication, and anemia can be presentation of lead intoxication. That is true. You should also know that it's a cause of developmental and behavioral changes and CNS changes that tend to be irreversible. So that is why it's very important. As Parisa said, in Iran, it is not very common, but I think here now we have two guests from other countries, one Muhammad and another one Ranga. Can you tell me if that is the case for your countries? Do you have many patients with lead intoxication in your countries?
In our country, I don't really know, but I just think it's common because I don't know. I don't know, but I think it's common because of some people, they don't use piped water, you know.
Yeah.
So
right.
I think there is a risk.
Yes, that is right. That is right. So Well, the sources for lead intoxication, as you have well mentioned, both of you, one of them is the intoxication of water. I don't think so, but I think in low socioeconomic areas, common, Mohammed says. Yes, that is true. We also can say that lead is found in batteries, okay, also found in some special paint material and in potteries and in some herbal medicines that whose source we are not sure about, okay? So if it is very important to ask if the patient has a father, for example, who works in a battery factory, okay, or maybe lives in a very old house with very old paintings and cracked paintings, or uses unsterile water or other sources like this, okay? We have the table here. Okay. So you should ask, this is the one about the building that I told you. You should also ask if there's a brother, sister, housemate, playmate, or someone around the patient who has the same problem. So that might be a common source for this child too. Does a child live with an adult whose job or hobby involves exposure to lead? For example, lead smelting and automotive radiator repair. This is another source too, but what we usually ask the patient, and it's very important, is the battery factory, okay? And also if the family uses home remedies or pottery from another country, there should be concerns about lead intoxication. And what is important to do is to check for the level of lead, okay? And we should go on. Tuberculosis screening. This is very important. Because in our area, well, we might even say that we are endemic for tuberculosis because of our proximities and our neighbor countries who still have tuberculosis, and they have traveled a lot here. And so now we can call ourselves endemic also. Can you tell me the risk factors for a child to be infected with tuberculosis? What you should specifically ask if it exists, and when there is, the child will be endangered by tuberculosis. You can both type or call. No.
I think children with immunosuppression and like diseases like HIV, cancer, leukemia going there. Then children coming from low economic social status, and even the history, family history. Maybe if there's anyone in the household with the infection.
That is true. As Ranga has well said, it is important to ask if the child Okay, guys, I'm sorry. I was shooted out, and then when I came back, I was muted. So I will explain again. As Ranga has well said, we should ask specifically if the child is immunocompromised or if anyone near the child is immunocompromised. Okay, you can hear me now, right? Because I'm a little worried that we might still have problems. Yes, can you hear?
Yes, your voice and
Okay,
Yes.
okay. So thank you very much. So what you should specifically ask about is if the child is under chemotherapy, for example, if the child has HIV, or if she or he has primary reasons for being immunocompromised, or if the same things are happening in the family, or if the child has contact with a recent traveler from endemic areas, or with someone who is using illegal drugs via IV routes, or things like that. Okay. So I don't know why this side here. So this is the table. I think we talked about it well. And another important factor is cholesterol screening. It is recommended to do this screening for all children between 9 to 11 years, okay, whether they have any risk factors or not. But if any child has risk factors, you should do the cholesterol screening in ages 2, 4, 6, 8, and 10 years, and after that annually. Can you tell me about some of the risk factors that Sorry guys, I had to change the route for connection because the connection seemed to be unstable. Sorry. You can hear me now, right?
Yes.
Yeah, sorry. It's good that we have two sources, but both of them are weak. Sorry. So, hi again. I'm awfully sorry, but it's really not my fault. I'm trying hard to keep being connected. Okay, so I'm with you now, sorry. And Professor Ziai, can you please make me the host again so I can do the screen sharing? So Professor Ziai has decided that I haven't been successful in moderating this class, and he has disabled my screen sharing.
Because I think the internet sharing is so poor
Yeah.
in other other routes.
Okay.
My internet is poor from this morning.
Okay.
Don't worry.
Thank you. Thank you very much. But I still want to share my screen. Yeah. Yeah, I want to be able to share my screen in either way. So I think I will call. Excuse me, just wait for 1 minute.
Okay. Can I answer your questions about checking
cholesterol?
hyperlipidemia?
Yes, of course.
Hypercholesterolemia. Yes,
please.
In family history, if there is the history of a heart attack or sudden death in the women under 55 and men under 60 years of age. It's important as a family history, positive, and also I think in the overweight and obese children, we should be cautious about hyperlipidemia in them, and we should take this.
Yes, that is totally true. Thank you very much. As Parisa has well said, if the patient has these risk factors, like obesity, like high blood pressure, like diabetes, or if there is anyone in the family who has the same problems, we should be concerned and we should check for cholesterol levels. Okay, I will talk a little bit without the slides and waiting for the share screen to be available. Okay, another thing that is very important to screen for are sexually transmitted infections. Okay, we might not we might be a little cautious to ask about this, but it is very important to ask about in adolescence. Okay, so do not hesitate to ask about it, because you are the physician and that is your job, and you should not be ashamed to ask anything from the family or from the patient. Okay. And also another important factor, another important screening is depression screening. It's very important. In adolescents, it should be screened annually. And each year, when the patient comes to you for the regular visit, you should ask about the determinants of depression. And if there is any doubt, you should refer the patient to a psychiatrist. Okay. So let's talk a little about the dental care. And you know that each, Jana, yeah.
Kowsae John, sorry. What about the ADHD? You know, nowadays
Yes.
lots of mothers are complaining for hyperactivity of their child.
Yes.
Is there any screening time or test for children in specific time? Or is according to the chief complaint of parents?
You know, in each visit, when the patient comes to you, or when the parents are coming to you for the routine visit, you should pay attention to the concerns. It is not there is not any special time suggested for doing this screening. Okay, but when the child in his developmental stages, or when the parents in their concerns are showing some signs of ADHD, you should do the thorough investigation and then refer to the patient to the psychiatrist. There is no special time. It is usually suggested to do this after 3 years, but in psychiatric references, because sooner than 3 years old, usually the ADHD is not completely apparent and cannot be found. Okay, but after 3 years, you should ask about the possible determinants, the possible signs, and then refer the patient. But for autism, it's different. For autism, it is said, it is suggested. Yeah, they're telling me that my video is off. Sorry. For autism, it is suggested that you screen in 18 months and in 2 years. Okay, for autism, there is a net suggestion. For ADHD, there is no special suggestion. Have I explained it fully?
Yes, thank you. Thank you.
You're welcome. I really want to share my screen, and I don't know why my host has disabled me and I cannot find it. Okay, so okay, let's talk about the dental care until we can find Dr. Ziai. And can I kindly ask Dr. Memarian, who I think is present here, to contact Dr. Ziai to please make my screen sharing available? Thank you very much. Okay, so about the dental care, we want to talk a little about the dental care. It is very important to do annual screening for dental problems. Of course, the dentist should do that. So you should refer the patient each time that he comes for a visit to the dentist. Okay, and there are some ways to no, still not available. There are some ways to make sure that less tooth decays will happen for the patient. Okay, some are available in our country too. For example, the fluoride use. I want to know if you have the same experience with fluoride wash, because usually in children in Iran, and we use that in children in school age. We ask them to do this fluoride wash every week, once in every week, and usually the schools are responsible to run the program. There is another way called fluoride varnish, in which the dentist will directly insert the fluoride on the patient's teeth with a brush. We usually do not do this, but the dentists can perform this if they're asked to, but it's not a routine here. Do you have the same experience with fluoride? Can anybody tell me if they have used fluoride therapy when they were little?
Yeah, I did it. It was not done on me, but I did it. It's kind of a prophylactic treatment for dental caries. So children's teeth, deciduous teeth, they are so soft, like their enamel is not yet fully calcified. So it's very prone to decay. So by applying fluoride, we are trying to strengthen the enamel by creating some hydroxyapatite crystals inside the tooth enamel.
Yeah, that's right. So I think that's a global program. It seems to be run in all the countries, right? Okay, anybody else? I'm still trying to get my slides. So. Okay, so that is what we do. And there is another way to prevent tooth decays, and that is using the sealants. The sealants are some materials that the dentists use to fill in the pits of the teeth. Okay, so if this is done early in the childhood, the teeth will be prevented from decays. This also is not usually done here in Iran, but the dentists will provide them if they're asked to. Okay, so it is good to propose these ways to the child, especially if their families are concerned about this, or if you find some risk factors for the tooth decays, to suggest the fluoride varnish, to suggest the tooth sealants that is not usually done here in our country. Okay, and after that. Okay, I can share my screen now. That is really great. Okay, can you see the slides now? If you can, this will be really great for me. You can see the slides now, don't you?
Yes, yes.
Okay. So I will introduce this subject, okay, because I don't think we have enough time for today, but I want to introduce the subject of growth today, okay, and the growth charts. Are you familiar with growth charts? Have you used them in your general practice? Someone is making lines on my growth charts. Okay.
Yes, always, and it's tools in the when we want to evaluate the growth of the children. Yeah. Yes, it's important too.
Well, that is great. Is anyone here who is not familiar with the concept of growth charts or have not used them yet? There are two ways. Either you have used them or you have not. So because only Parisa said that she has used them, I assume that others have not. So tell me if you have not used them, because I want to know to which degree I should explain about it.
In Darumga, I think I once used them, but I think there's no harm in repeating.
Okay, so great. So here you can see the growth charts proposed by CDC. I know we are a little out of time, but because there were many problems with connection and we started a little late, I think we will have about 10 minutes more. Okay, so look here. It says birth to 24 months, okay, to 24-month boys. So this chart is for boys. It is usually blue, sorry, the charts used for boys, and usually the charts used for girls are pink. But sometimes they are of neutral color, they are black. So check for the names here, boys or girls. So these charts here, this is for length for age and weight for age percentiles. As you can see here, these are the percentiles for weight for age. This is the age here, and this is the weight. And here we will have the age and height, okay? We usually call the height length when we are using it for the less than 2-year-olds. Okay, so you can find the place of the child's growth on these charts. For example, if a patient who is 3-year-old, okay, 3-month-old, has a weight of 7 kilograms, you can find it here. Okay, this is 3 months, this is 7 kilograms, and this is near the chart of 75%. Okay, the percentile of 75. Okay. And here we can also find the length of that patient. For example, if the 3-month-old is, for example, 60 centimeters tall, you can find it here, 3 months, 60 centimeters. It is near 25th percentile. This is very important in evaluating the growth of the patient. Why? Because both at this time and even after this time, for following the patient's growth, you can use this chart, okay? It might be, the child might have a low weight now, okay? But in the follow-up visits, the weight will change and you can see the velocity of change. For example, if the child's percentile here is the 50th percentile and the next time is the 25th percentile, you will be worried that something is happening between these times. But if the child is always moving on, for example, the 25th percentile, we can say that, well, the child's chart, the child's percentile is the 25th. It's not that much worrying as it would be if there was a decline. Okay, you understand my point? The importance of growth velocity can be shown here with these charts. Okay, and we have the different charts for girls and also for different ages. Okay, because these ones are birth to 24 months, we will have 2 years to 20-year-olds. Okay, and also here we will have the chart for weight for age and hip circumference for age. Hip circumference is a very important factor in showing the development and showing the growth of the child. It should be measured until 2 years old, because usually more than 2-year-olds will not have problems with their hip circumferences and it will not change a lot. But up until then, you should check for it in each visit, okay? And this chart here, the chart for weight for age, is important for finding undernutritions and obesities, okay? Because I want to make sure that you're okay using the charts, I have put here a case. I want you to show me the growth of this patient, a 2-year-old boy whose birth weight was 3,400 grams, birth height of 50 centimeters, and head circumference of 34 centimeters. You can leave the head circumference, just draw me the chart. I will give the picture of the chart to you. I will share it here in the chats. Okay, let me do this here. I will try to do this. I will share a Microsoft Word version of my charts. You can use them freely then. Just try to show the growth of this patient to me, because I want to know how much you know about this. And if we are out of time in the next session, I want to talk about the reasons for children's being short, okay? And it's a very important topic, I suppose. So just let me find it now. I will send it to you, and please just draw me, show the dots on the chart that I give you. Wait a little. I have hidden it so well that I cannot find it. Why can't I find it? Okay. Sorry, there's a problem again here. I cannot give you the word file. So let's do this together. Someone be volunteer and let's start together. Okay? Just tell me on which percentile it will be. We have a child with a birth weight of 3,400 and birth height of 50 centimeters. Someone please be the volunteer and help me just draw the dots here on this chart. Who is a volunteer? It's very easy.
If there is no volunteer, I do.
You're always a volunteer. You're such a dear. Okay.
Okay. The birth weight of 3,400 is on the fifth percentile. And yes, here.
Yes.
And the height of 50 centimeter, isn't it?
Yes, it's 50
also
centimeter.
on fifth percentile, and it's good. It's excellent for and ideal for a newborn, as he or she become 6 months of age. He become 8 kilogram. That it means that the growth velocity is followed on the fifth percentile, and his or her height is on 67 maybe.
Yes, that is great. It is here.
True, yes, exactly. But through 2 years of age, his weight is 10 kilogram. It means it diminished to the fifth percentile, from 50 percentile to fifth percentile. It cross 2, or we can say 3 percentile, and it's the worst, and it should be analyzed and examined for the the reason that caused this growth retardation. And the height is on what?
The height is 84 centimeters here.
The height is 84 centimeters, so the height is on 2, 3, 4, on 25 percentile. It's also diminished from the original milestone. So this failure to thrive affects both weight and height, and so important, and should we pay attention to. Where's the host?
So we must do investigations when the growth pattern crosses minimum of 3 percentiles, right? Like 3 boxes.
Ranga? I did not understand the question. Did you ask, because I was disconnected and then got connected and I missed it, if you were asking for the investigation that we should do?
That's true. Like, what is the indication? Is it like if the growth pattern, like it jumps 3 boxes, 3 percentiles? Is it like the indication of investigation?
Okay, so what is very important for knowing about short stature and also for loss of weight is to know that any decline is important, okay? We can say if, for example, a patient is born on the 25th percentile, under 1 Z score or 1 percentile lower than the normal percentile, okay? It is acceptable, okay? And if the patient goes on like this during his life, but if there is a decline, a sudden decline from
any time in the patient's life, okay, any decline is important and it should be investigated, okay. But we have some special charts for this. We can say that, for example, if a patient comes to you and you understand that the percentile is 1 lower than the normal, then you should do some further investigations. You should make sure that this is not acute, that this has been the same thing for all of this time, for all of his life, and that the patient is not having a problem, a systematic disease, for example. You should do some laboratory evaluations, okay? And if everything is okay, you can just leave the patient be, okay? But more than 1 Z-score lower than the normal limit is always important, whether this is acute or it's not, it's chronic, okay? And this is a topic I want to talk about in the next session, because this is a very vast topic and there are lots of things to be said about it. I have the reasons for shorter stature and the reasons for being underweight and the evaluations that we should do. If you think it is a good topic, we will make this the next session's topic, because I think we are not allowed to have this session for more than 45 minutes. And I have been disconnected for, I think it's thousands of times. And if you let me, I will continue this session the next time. Is it okay?
Yes, of course. Yes, Kowsae John, I have a question. When we use the chart of weight for length, you know, I don't use it. Usually, I don't use it. I mostly use weight for age and length for age. But weight for length, when we use it?
It's usually to evaluate malnutrition and also obesity, okay? If you want to follow the patient, you want to understand if the patient has changed according to weight or according to height, the easier charts to be used are weight for age and height for age. These are the normal charts that we use, okay? But in order to find malnutrition or obesity, the chart for weight for height is better. And if you have, for example, if you assess the weight of the patient and you understand that he is malnourished, that he is more than 1 Z-score or more than 25 percentile low in his normal weight, okay, then you should be referred to the weight for height chart, okay? Or if the patient is obese, if the patient has more than one, is higher than 1 Z-score in his weight, for example, okay? So this is when you change into that chart.
So you mean that, for example, if a child has a weight and height both on the 3rd percentile, but on the weight for length chart, we have the 5th percentile, he is okay. And he is not malnourished. It's, for example, it's the shortest, shortest stature example or something. No, not shortest stature. I mean, reason is Asna.
You said that he is on the 5th percentile for height, right?
On the chart of weight for height, for example, it's on 5th percentile, but on the chart of weight for age or length for age, he is on 3rd percentile 3. I mean,
normal percentile.
For example.
You mean normal? 3rd percentile?
Not normal.
You mean?
No, I don't mean or less than 25th percentile. So like I said,
a 3rd from the below. Okay.
Yes.
No, this is not normal. Look, first of all, when you evaluate the child, okay, right now, not comparing it with before, okay, just right now, okay, you're just estimating the child's height or weight right now, okay. If you find that the child is not on the 50th percentile, for example, 1 Z-score lower than normal or 1 percentile lower than normal, okay, this is not normal. If this is happening, you should be referred to the chart for weight for height, okay. Then you will check there if there are problems, okay. If there also you have the child for more than 1 Z-score or more than 1 percentile limit lower than the normal one, then there is a definite problem, okay. So you will survey more. So the chart is used only when there are problems. If the patient is having a normal growth, you do not need to change your chart to those charts, okay? Because they're a little more difficult to use, and you cannot interpret if the height has differed, for example, from the next time, or the weight has differed. Okay, because it shows the ratio of weight for height. But if the weight for height has decreased, it is a sign of malnutrition. If this has increased, it is a sign for obesity. Okay, the definition of malnutrition and obesity is a little different for just underweight. Okay, underweight means just lower weight. Malnutrition means that the patient is being compromised somehow. There is a problem. Maybe the height is low, maybe the weight is low. Okay, you cannot understand this definitely without surveying all the problems of the child. Okay, that is why in a normal child you cannot work with that chart for weight for height, because it does not give you or the mother any clue about the height or the weight of the child. It just gives the ratio. It just will tell you about the malnutrition or obesity. I think if it's a little hard to understand, I should share the charts for weight for height, specifically for any age, and the definitions of malnutrition and the definitions of underweight and overweight the next time, if you're okay.
Yes, of course. Thank you. I do appreciate.
Okay. Just keep working with the weight for height, weight for age and height for age chart, okay? Unless you find any problem. And if you find any problem, refer the patient or check the weight for height chart, okay? Next time I will explain why, okay?
Okay, thank you. Okay.
I apologize for the problems of connection. I think this was an introduction, and I had to give you the introduction for just entrance to the more important matter of nutrition and malnutrition and overweight and obesity and so on. And I think the next session will be more interesting. I will try to share the charts before the class with you so that you can work with the charts yourself. And thank you very much for your participation. And thank you, Dr. Nabiafar. And thank you, Ranga and Parisa. And thank you, Parisa, very much for your participation and for active participation, and also Ranga. Thank you, guys. Goodbye.